Good evening, everyone. Welcome. Thank you so much for joining us on this Thursday evening, particularly because it's a Thursday evening right before a long weekend. We've got a really interesting evening for you for the next 90 minutes, so it's a bit jam-packed, and we're going to make sure that we get through it all with lots of time for questions as well. Just a little bit of housekeeping before we move on to the interesting presentations. I just want to make sure that we take a moment to acknowledge the traditional owners on the land on which we meet today and pay our acknowledgements to their elders past, present and emerging. Just some general housekeeping, which is really important for our webinar time. All of you are at home or on mute, so that's all done automatically for us. So the way that you're going to communicate with us is using the question boxes that should be up on the side of your screen. So when you actually have a particular question that you'd like us to ask the presenter, please put it in the question box. There is a second chat box that you can use if you wanted to chat to the admin people. So I'm one of those, and we've also got Madeline online as well, who'll be looking after you as you type in your questions. And there will be some question time available at the end for each presenter, and then at the very end as well if we also have a bit of time. So please make sure you send your questions through, and we'll do our best to make sure that we get those addressed for you. At the end of the webinar, as always, we'll make sure we send you out an email that has the very important evaluation survey. So we really encourage you to take just a few minutes to complete that for us. It really allows us to make sure that we're running education that's relevant for you and in a format that's really good for you as well. And then sometime next week after Easter, we'll make sure that we get your certificates of attendance sent out as well. While we've got you captured here, just a bit of shameless plugging for what's coming up and what we've got happening at the Northwestern Melbourne Primary Health Network, some other education sessions that you might be keen to jump online with. Now we've got a bit more time at home to spend doing this kind of stuff. So we've got next Thursday evening, we've got the adult vaccination update. So this is the second time we're running this. We ran this one a few weeks ago and that was really popular then. And that's with Dr. Peter Eisenberg, who is exceptionally knowledgeable in this area and has a really detailed presentation on all things adult vaccination. So I'd encourage you to take the time to come and join us with that one. Later in the month, we've got the practice managers meeting. So for any practice managers that are joining us tonight, normally we run these sessions face-to-face and we actually run them within different sections of our catchment. So normally one in the west and one in the north, further out north and one central, but because of obviously the climate at the moment, we're having to run those by webinar. So you are welcome to attend any session that is at a date and time that's suitable for you. We've got some running over the lunch break and others towards the end of the day. And I believe we've also got Rivka presenting at that one for us as well. We've got an STI, so sexually transmitted and infections and PrEP update for primary care webinar happening on Thursday, the 23rd of April. That's a great session run by the Vital team, and you're probably aware that STIs are actually a really big issue for our catchment. Chlamydia, gonorrhea, and particularly syphilis at the moment. We have some outbreaks in some of our suburbs, even out in the Melton area. So highly recommend nurses, general practitioners jumping on that session, anyone else who's interested as well. My health record for specialists and practice managers, there's an update on that and using that effectively. And I did mention the practice managers meetings. We also have practice nurse meetings as well, and they're coming in May, so keep a lookout for those. I've been asked to just talk to you about our think tank and encourage you all to sign up if you're interested. So what our think tank is, it's basically a group of people that have registered who are interested in potentially being a part of some of the projects that we run here at the PHN. We really like to be able to go out and get feedback or consult with health professionals that work in a catchment in the primary care setting. And if you sign up for the think tank, it's really important to know that you're not actually signing up for a huge amount of work. You're actually signing up to whatever you choose to sign up to. So we will forward you out any opportunities that have come about. And it could be, for example, being on a consulting panel, reviewing some documents or some resources that we're developing and get your feedback on those. All kinds of things that we reach out to health professionals for. And when we do reach out to you, you don't have to say yes, but you're absolutely welcome to partake in those opportunities, and quite often we're able to pay you for your time in that as well. So whether you're a nurse, a GP, any other primary care, if you're a practice manager in the reception team, any of those areas at all, pharmacists, we'd love to have you on board because we need all kinds of health professionals contributing to the work that we do. And another important one for practice managers and practice nurses, we have what's called a base camp. I guess it's kind of a chat group, a blog, I guess you might call it, that are separate, one for practice managers and practice nurses, where it's basically your forum for our catchment area. Practice managers and nurses will go on to their base camp sites and they'll post questions, they might post jobs potentially, or have discussions about things that are relevant to you. I know there's a fair bit of stuff, discussion happening around the COVID stuff and how each practice is coping with that. So we encourage you, if you're not signed up for either the think tank or the base camp, please let us know. You just need to get in contact with us, and the information of how to do that will be sent out into the email that follows on from tonight's session. Really important for us to just remind you, for all practices, I'm sure you're doing this, and we know that our catchment from the discussions we've been having with our practices are going really well and working really hard to make sure that they stay up to date with everything COVID related. And as I'm sure you're all aware, it's changing rapidly and daily. So it's really important to stay up to date with the guidelines. The DHHS website's really good for that. The PHNs are putting out regular updates, either daily or every second day, depending on how quickly those changes are happening. We basically surmise that information and put it down into really relevant stuff for our catchment, the big highlights of the changes. Other alerts, and don't forget the hotline number, have that somewhere that's an easy to reach place as well. And again, if you're not receiving some of these updates, particularly the PHN updates, please let us know and we'll make sure that you're getting those. Something that happened today, well, for our catchment, came out today. As you're hopefully aware, Health Direct, which is the video conferencing platform, has been made available to all general practices. So in the PHN catchments, we're responsible for helping to onboard the practices within our catchment who are interested in accessing that Health Direct platform. And that access is, as far as we're aware, happening until June 2021 at this stage. So the expression of interest came out in the news bulletins today from the PHN, where there's a link in which you can register your practice. So one person from your practice just needs to go on and register that if you're keen to have access to that platform, and then one of your relationship managers will be in touch with you very shortly to set up a time to get you up and running for that. So just again, that's a free service. It's now completely available to general practice, and so please let us know and please fill in the registration form if you'd like to access that. I think I've done enough talking, so we'll get started in introducing our presenters. So we've got really lucky, we've got 3 presenters tonight, all bringing a slightly different perspective and different experience with telehealth. So we're going to start with Rivka Hagen. I've got a little spiel for you because it's very experienced. So really lucky to have Rivka here tonight. So Rivka's experience in general practice and primary care business management spans over 20 years and includes really like direct management in small, medium and large rural medical practices. And she also has many years as an accreditation surveyor. And so brings a huge wealth of knowledge to the health sector. So we'll hand over to Rivka, and we're going to hand over to, she's got some slides, I think, to run through with us. So we'll just get that handed over for her.
Alrighty, I think those slides are up and I think we're good to go. So thanks very much for that introduction, and welcome everyone this evening just before Easter. I hope you're all going to have a great break, and I hope the week has been kind to you in terms of your responses to COVID as well. Let's get straight into it. We have quite limited time and quite a lot of content to get through, and as indicated, we're going to be held to the times that we have available. So let's get started. Before we do kick in, I also would like to acknowledge the traditional custodians of the lands on which we are virtually meeting this evening and pay my respects to their elders past, present and emerging. And also a very warm welcome to any representatives who may be attending the webinar tonight, or if you are viewing this later, also a welcome to you too. Just a quick recap of the housekeeping. So please do keep your microphones on mute. Add your questions and comments through the chat box. I won't be looking at them until the end, just so that I don't get distracted by that. And a reminder that the session will be recorded for your later viewing as well. So we're going to have a really good deep dive into all things Medicare and telehealth and all of the changes that have been foisted upon us since the 13th of March, which it kind of feels like a long time ago, but really it was only a couple of weeks ago when this whole space of telehealth, video conferencing and telephone services became a real opportunity for general practices. And I'm sure like other practices, you've had to really work hard to get your head around what are these new items, how do we apply them, how do we run our models, how does this actually work? So you will know that there are now a whole lot of item numbers for standard consultations, for mental health service plans, and for chronic disease services as well. There are also item numbers available for the Aboriginal Torres Strait Islander health assessment and a whole raft of other services as well. I've got them outlined here. They are related to autism, support for pregnancy, eating disorders, and also for urgent after-hours care, although interestingly what's absent from the current offers is just the more routine after-hours services, and I know that that causes quite a bit of consternation to the practice managers out there. Interestingly too, the normal health assessment items for the 701s to the 707, so these are the time-based health assessments, are not available. I guess I'm not too surprised by that, in that many of these health assessments really do require a physical attendance by the patient in order to take some metrics and to do the health assessment justice. So my take on it is that that's the reason why these haven't translated into the new item numbers. What you need to know about too, and probably you already do this at this stage, is that there are some additional dollars on the table now in relation to the incentive for bulk billing. So you will know these as your item numbers 10990 and 10991s for the more rural-based practices. And these now attract a double rebate compared to the pre-COVID-19 space. So that's a bit of recognition for the very tricky space that we're working in now, and of course that's very welcome for everybody, and it really will support that ongoing bulk billing for most of the practices out there. So that's a welcome relief. The QIPIP, so for practices who are registered for the Practice Incentives Program, so these will be practices who are accredited and have actually signed up for the QIPIP component of this program. For 6 months, you will be getting a double value of your practice incentive payment. And the only requirement to be able to tap into that is that your practice still needs to be able to offer face-to-face services for patients for whom that is the most appropriate mode of care, and that needs to be available for a minimum of 4 hours a day, or 50% of your total service if you don't quite have your services open on a full-time basis. Now, the way that will work is you will receive that double QIPIP next month in April, when the next Practice Incentive Program payment is due, and you will get that again then in August when the next cycle comes through. And I've put a URL link down below in terms of where you can get all of the information regarding the bulk billing items and the new item numbers. All of these links are all together available through one URL that I will give you at the end of this presentation as well. So don't worry too much about scribbling down this long line. There's just one URL at the end that you will need in order to tap into all of this information. So they were the changes that were affected on the 30th of March. And last Sunday, as you'll know, Scott Morrison is a fan of announcing on Sunday afternoon all of the changes that are happening in this space of COVID, and the Medicare changes are no different to that. So last Sunday was announced that the bulk billing requirement, which was in the early space, so the first couple of weeks of these new items, all patients needed to be bulk billed in order to use the item numbers that were made available. That's now been amended in that bulk billing is now a requirement for concession patients. So that is patients with a healthcare card, a pension card, children under 16, and also that group of vulnerable patients. And I'll run through what that means in just a moment. But they have loosened up that billing space in that you are permitted now to private bill for patients outside of those concession and vulnerable patient groups if you so choose. Whichever way you decide to go in terms of how you're going to be remunerated for these services, you've got to get patient consent in order to supply both services. And I guess there is that element of implied consent in that if you have established a telephone consultation or a video consultation, then I guess you can take it from that there is consent for that service to take place. But you do need to be really clear about any fees that may be attracted by using this service. So you've got to be really transparent about how this is actually going to play out. So I've been a busy beaver over the last couple of weeks in translating the item numbers from the general items that you will know and recognise. They are listed down the left-hand column for the existing items, just down here. So you will recognise these item numbers as your standard consultation items, the attendance items, and then all of the other items which are now available for telehealth services. In the green column, you'll see the telephone items, and in the blue column are the telehealth video items. And I guess this is where the complexity comes in, because all of a sudden one item number has now turned into 3 item numbers, and it's really quite tricky to keep track of what you need to be charging for what kind of service. So various guides were published over the time that these items became available, and I've simply put them together to be just an easy ready reckoner, as well as the Medicare rebates, just so that you can see very clearly what the fee is going to be that your practice is going to get paid. Now you'll see the little blue arrow pointing to the purple column for the Medicare rebate at 85%. And this has caused a little bit of confusion too, because your standard Medicare items for just face-to-face attendances, for the most part, they are paid at 100% of the Medicare rebate. But in this case, the rebate is actually paid at 85%. However, what Medicare have done is they have made the actual scheduled fee higher than what it is for the equivalent attendance items, so that when all is said and done, at the 85% rebate amount, your practice is going to earn exactly the same dollar amount for the service as you would for a face-to-face consultation. And I hope that's not too complex, but the fees are there and they are outlined. And remember, of course, the double 10990, the bulk billing incentive item, it applies to patients who are eligible for that item number, and the eligibility is the same as what it has been before the COVID-19 space. So it will be attractive for some patients, and other patients they won't be eligible for that bulk billing incentive item. Here's just another slide with just an example of other medical practitioners, and that relates to non-vocationally registered GPs. Same deal, the existing item numbers on the left, the telephone items in the green column, and the telehealth items in the blue column, with the Medicare rebates that you're actually going to get paid. So, and again, I won't spend too much more time on that. So let's have a talk about the assignment of the Medicare benefit, because that's a pretty important consideration here. And this is trickier now, of course, because the patient isn't in front of you. So you'll recall that before these telehealth COVID-19 item numbers came into play, that Medicare requires the assignment of the Medicare benefit to the GP who provides the service, because the Medicare benefit is actually a fee that rightfully belongs to the patient, not to the GP. And it's that process of assigning the benefit that transfers that fee from the patient to the GP. And in a normal circumstance, the way that that is affected is by patients signing a bulk billing voucher on a piece of paper, or pressing the tyro button if you've got a tyro machine. So those are the two ways that you can lawfully, legally assign the benefit over to the GP. What happens now is that obviously the patient isn't in front of you, so they can't press a button and they can't sign a bulk billing voucher. So the rules have changed just a little bit. You still need to assign the benefit, and that assignment agreement needs to be documented. But you can get verbal consent for that assignment to take place. So this may require you to have a talk to your GPs, because they may be involved in conversations that they usually have nothing to do with. And so you need to think about how that's going to work for your practice. If you are using your health record system, it is probably the most easily done by creating some autofill prompts for your GPs for the telehealth or the video consulting services that you might be running. Now, interestingly too, Medicare has indicated that over the time of COVID-19, there will be no auditing of the assignment of benefits. And you can read into that what you will. Clearly, you know, Medicare has been quite active in the space of auditing practices in lots of different areas, including assignment of benefit, but they have specified that that audit is going to be on hold. However, I really do recommend that the documentation, the noting down in your health record system or another way needs to take place for you to have lawfully assigned that benefit over. So how might you be able to do that? You could think about doing that at the commencement of the telehealth or telephone service at the booking time. So what you might be saying to the patient is indicating that the consultation is going to be bulk billed, and simply seeking their consent, that they're happy for that to take place. And you might record that in your appointment booking system. I would presume that patients are going to consent to that. It's hard to imagine a patient saying no, but if they do say, oh, I'm not so happy about that, you may need to be thinking about applying a private non-Medicare type of fee to that service. That's a pretty low likelihood that you would find yourself in that space though. And then perhaps at the completion of the service, what the GP might do in order to sort of expedite that, that charging and the completion of the service is simply describe to the patient what is going to be put through to Medicare. So describe the attendance, whether it is a standard consultation or whether it is a mental health care plan or any other service that is eligible under this, this telehealth system. And you will indicate to the patient that the claim is going to be submitted to Medicare. You can tell them what the rebate is going to be if you've got the Ready Reckoner next to you, and that's easy to see. And you might also like to advise the patient that you may be entitled to also receive a bulk billing incentive, which is that 10990 or 10991 number. And if you cover all of that off, then certainly you've met that requirement for proper assignment of benefit. But of course, you might be wanting to think about some private fees as well. So the Medicare benefit schedule items before this week required bulk billing pretty much for anybody who was receiving such a service. But since the start of this week, from the 5th of April or the 6th of April on Monday, the requirement from Medicare is that you must bulk bill concession card holders. So I've run through those categories previously, and I'll run through the vulnerable patient group in a moment as well. So the bulk bill incentives apply. So think about that. The double bulk bill incentive may make it far less feasible for you to consider charging private fees. You can also choose to privately bill and not apply any kind of telehealth item number to it. Again, you might want to think about that, but do that at your peril. You'll remember that the patient is able to achieve their services from many different providers, and so you need to be careful about thinking of applying private fees to your patients. Think about your location, think about your competition, and think about where your patients might be receiving their services from. Think, of course, too, about your patient hardship and just the very rapidly changing economic conditions that we are all experiencing. So what held true last week, we're in a different space now, or even a couple of weeks ago. So think very carefully about your billing policies and what it means for your patients, for your clientele, for your loyalty, and what you actually need to do to keep your business viable and still look after your patients as well. So just a quick run through the vulnerable patients category. So you will remember that your concession patients and children under 16 must be bulk billed if you use the telehealth item numbers, but there is also the vulnerable patients group. So that's slightly new in this whole space, and you need to remember who they are so that you will recall that these patients also must be bulk billed for the services that they receive. So these are patients who are required to self-isolate or be in self-quarantine in accordance with whatever the current guidelines are at a point in time. Anyone who is 70 years old or older, any Aboriginal or Torres Strait Islander person who is at least 50 years old, any pregnant women, any parents of a child under 12 months, so parents of babies, anyone being treated for a chronic health condition, anyone who is immune compromised, or anyone who meets the current National Triage Protocol criteria for suspected COVID-19 infection. So that's quite a large group of people that also you should not be privately billing if that's the way you're going anyhow. Of course, if your practice has decided to bulk bill all patients that are receiving telehealth services, then you don't really need to think too much about this because they will automatically fall under that billing policy. So let's have a quick talk about your booking processes. How do you go about actually booking in your telehealth services? Because it is quite a different dynamic to your usual face-to-face consultations. And I guess overall, no practice quite works the same as any other practice. So you need to think about what's going to work for your individual circumstances. Think about what your specific triage processes look like. And you might be thinking about adding new resources to appointment schedules. So if you think about your medical director or your Praxsoft appointment schedules, think about adding a new resource, which might be your telehealth service, or you might call it COVID-19, or you might call it a fever clinic. You're going to call it whatever best describes how you want to allocate your patients, or you might even have separate columns for each of those sections. Again, you need to talk within your team to work out how are you going to see these patients, who's going to see them, how many columns do you need in order to make that work. You also really need to keep in mind where the service is being delivered from. So for GPs who are still working from their practice location, that might be a different setup to what it might look like for GPs who are working from a home base. So think about the scheduling and the workflows that you need to keep in mind in order to make that work effectively. You also might, again, think about adding the consent to bulk billing documentation at this point in time when patients are ready to book in for the service. Think too, of course, about your staff and GP training. So everybody needs to know what is your new system. Everybody needs to be singing from that same songbook. Everybody needs to understand the system so that you don't have errors occurring and possibly, patient attendances falling between the crack or the system simply falling apart. It's another really good idea to think about putting together some instructions for your patients. So have some sheets ready that explain to patients how their telehealth service is going to be delivered. And you might, again, need 2 different instructions for whether they are receiving a telephone instruction or whether they're receiving a video attendance. They're quite different modalities. It's going to require a different approach, and your patients need education in order to understand what's expected from them in this new service delivery space as well. And finally, in terms of booking processes, I'd really encourage you to just put in place small changes at a time. Keep reviewing and refining your processes as you go, and really look at it as a quality improvement activity. And you will get better at this the longer you use it, of course. So try small, involve your team, use your communication to ensure that you get the perspective of everybody's needs in this space, and you're much more likely to end up with a system that's really going to work for you and your GPs and your staff, and of course your patients and your clients as well. So now we get to deciding whether we're going to be offering a telephone or a video conferencing service, or whether you are going to be providing a little bit of both. So let's have a look at your telephone services. The feedback that I've been hearing from GPs is that that's the easiest to implement, and I'm hearing this from practice staff as well. And the reason it's easy, it's because everybody has a telephone and everybody knows how to use a telephone. So from a technology point of view, there is a simplicity in there that makes it really quite attractive, especially in the early days of COVID-19, while we are dealing with many stresses within our practice, that we have reasonably simple technology to support the service provision. You need to think about the workflow and the considerations that relate to that. So you need to think about, how does the patient get in touch? How do you establish that connection? Is it the GP who calls the patient? Is it the administrative staff, your receptionist, who makes that call and then transfers it through? Again, think about who's located where and what is actually going to work the best. What you do need to think about in terms of telephone services is that if that is the only modality you use for providing your health services, is that you are, or your GP is going to be missing some really important visual cues. So usually, of course, with the GP face-to-face with the patient, there's a lot of information that the GP learns from the patient by having them physically present and being able to see them as well. On the telephone, all of that is missing, and so a huge component of communication falls away. And what that means is that it can be easier for important information to get overlooked or to not be observed. And there is a question just about the long-term sustainability of using a telephone all day for many days to come. You can imagine if you are on the telephone all day to a person or to various persons, how tiring that is. And that's certainly the feedback that I'm hearing, that a telephone conversation as a one-off is absolutely fine, but as an ongoing modality is really very challenging for GPs. And I'll be very interested to hear Todd Cameron's perspectives on that as well. With regard to the video conferencing, you need to think about the patient usability, and that really comes down to what sort of technology are you going to be using to make that connection. You're definitely going to see better clinical decision making because the visual aspect has been reintroduced. So it's a little easier for GPs to sustainably use that service for a longer period of time. And you also want to think about the benefits of being able to offer these kinds of services after COVID-19 has been and done. I know that that seems quite a long way away, but think about how these kinds of services could be an offering that becomes part of your normal services after this crisis time is over. You also need to be thinking about your technical considerations, what audiovisual hardware you're going to need. So that's talking about cameras and microphones and speakers, what is going to work and integrate with your current IT system. You need to think about your internet capacity and your capability there, and certainly broadband is an issue in many places, so that could definitely be a limiting factor. And you need to think about, well, which way are you going to be interacting with your patients? What sort of platforms are you going to be using? There is a service available through Health Direct that I know some PHNs are supporting in terms of giving free access to practices to be able to use that. That's kind of nice because it is a little more sort of fit for purpose for the use of video conferencing in the health sector. So have a look at that platform to see whether you might think that that meets your needs. But other services that practices are using include Skype and Zoom, FaceTime, WhatsApp. There's also a newer product, CoView, which also has some really nice features. And there are a myriad of other services available as well. Again, in terms of what works best, the feedback that I'm hearing is that services that are web-based for the patients tend to be easier to get onto and to maintain than any kind of platform that requires a download or another program to be installed on the patient's side. So have a think about what's going to suit your clients. Think about the demographics of your patient base and what is going to suit best. And think too whether perhaps you're able to offer a range of options in accordance with your patient's preferences as well. If that's going to be the case, think about how you're going to capture that information at the time that appointments are going to be booked, so that everyone's clear about how we're connecting to patients. So there's definitely complexity in all of this. So in terms of the practical considerations for delivering telehealth services, for video consulting, what I'm hearing again from the coalface is that a dual screen is kind of easy because it allows a GP to both be looking at the health record system at the same time as seeing their patients as well. So having two screens to be able to do that is far better than trying to toggle between different fields within the one screen. GPs need to remember that identification of the patient may be a requirement now that hasn't been there previously. So they need to be really sure of who they're talking to when they commence a telehealth service. So just go back over that accreditation requirement of the 3 approved identifiers to positively identify who you're providing your services to. You also might need to explain the limitations of telehealth to patients as well, so that they understand that it isn't a total replacement for health services, of course, and there may be circumstances in which the telehealth service is not sufficient to take care of the patient. There are issues also to do with the IT security of the telehealth connection. And so definitely the recommendation is that encryption should be in place at both ends, and that not all of the video consulting providers comply with that. There is definitely some chit chat about whether that matters so much or not. But when you think about normal sort of privacy and confidentiality requirements, the better that you can tick that box, the better you're able to protect that privacy and security for your patients as well. So think about which platforms and ask that question about how the platforms that you're looking at actually perform in that space. Think too about how you might be able to incorporate some home measurements that patients may be able to undertake from their home base. And an example of that might be blood pressures or blood sugar readings, and how you might be able to encourage patients to bring those readings or to actually take those measurements at the time that a consultation is in progress. That's definitely going to add to some of those quality markers as well. And there is also the issue of the documents that may be produced as a result of that consultation. And you might want to be sending some files like referrals or scripts or other documents to another place from where you currently are. And this is particularly true if GPs, of course, are working away from the practice. Then that becomes another issue that you really need to think about carefully. There is a really terrific system called Firefox Send that allows you to really send any document in an encrypted method very quickly, very easily. You don't need any accounts, and I'm going to give, or as part of the URL link at the end of this presentation, there is actually a link to how you can get that up and running. So that could be a terrific way for GPs to get a referral straight through to a specialist, or to deliver a script straight through to pharmacy as well. Think too of whether you have the ability, or whether the GP has the ability to print locally, so from their home base, if that's where they're working from, in order to sort of help that document management as well. So some systems will allow for that a little bit better than others, but those are the areas that you need to be testing before you embark holus bolus on video conferencing services too. And think too about the arrangements that you might need to put in place with your pharmacists in order to ensure that they are clear about what they might be expecting in terms of how documents and scripts are going to be delivered to them over this period of time. So in relation to prescriptions, it is expected that in May 2020, so next month, that paperless e-scripts will be finally enabled, and gosh, can't it come soon enough. At the moment, you are still required to create a paper script and have that signed. An electronic signature on that is okay too, if your systems allow you to do that easily. It has been determined that scanning the script as a photo or a PDF is actually quite okay. So there is a little bit of flexibility about how you get that script across from the point of creation to either the pharmacy or to the patient, if that's where it's being delivered. However, the script has to include the barcode, so you need to ensure that you've got your e-script system up and running. So make sure that your ERX or whatever system you're using for your e-scripting is actually functional, and that your scripts are actually printing the barcode, because without that, things are going to not go quite right. And then you're going to send it to the pharmacy via fax, text, or email using those systems, or you can mail it to the patient again via the same type of via the same modalities there. There is an expectation that the pharmacies will have the capacity to deliver scripts to the patient, and obviously that would depend on the location of the pharmacy in relation to the patient, but that is definitely an expectation of the Department of Health, that pharmacies are able to support that as well. But this way of managing scripts at this point in time does not include Schedule 8 and Schedule 4D medications. For example, fentanyl or opioid scripts. They still need to be managed in the old way, as you will already be familiar with. So let's have a quick look at managing some telehealth risks. So what you want to be thinking about is, before you embark on a telehealth consultation, is whether that service is clinically appropriate for a telehealth service. You might want to think about too whether or how you're going to be assisting patients who are more seriously ill and for whom these kinds of services may not be the right way to go, or how you're going to manage patients whose health is declining. So there just might be a progression of illness, and you need to ensure that your systems are capable of having a response in those circumstances. Definitely a great idea to have a talk to your professional indemnity providers and ask them about the telehealth services, what their expectation is in terms of indemnifying the practice and the GPs through working in that space. And they are all certainly very proactive in supporting this, but you need to be across what their expectations might be of you as well. You need to think about what risks does your practice encounter from the fact that you are rapidly changing your processes. And of course, that in itself is inherently risky, that when you are introducing rapid change, that things may go wrong and that outcomes may not be predicted, and they may come upon you before you've had a chance to really contemplate them. So the recommendation there is to just really take a step back too from all of the rapid change and ask those questions about what are we missing? Is everything safe? Are we ticking all those boxes and approaching that as robustly as we possibly can? So think about the privacy risks associated as well. We've talked about security and encryption. We've also talked about the quality of the service. So how do you maintain service quality in the face of this very rapidly changing space? Think too, in terms of telehealth, that the chat boxes, so as you'll know with the webinar tonight, you're typing your questions into chat boxes. When your GPs are delivering health services, there is a recommendation that chat boxes aren't used because there is some privacy risks associated with the way that that information is captured and stored, and that information is retained as well. And think about the risks with regard to patient identification, that if you don't get that right from the outset, and the heightened risk of that identification not going quite right, that could be really problematic as well. So in terms of the overall COVID crisis risk management, there are some other considerations that you really do want to keep in mind as well. And probably top of the list, and certainly for me, it's the safety of all of your staff. You need to think about what your continued operation means for your staff and their well-being and their health as well. Think about your emergency response planning tool. You will all already have some kind of risk register and emergency planning response in place. You should have if you are an accredited practice. Think about updating that and really looking at all of your processes from that perspective of risk and emergency planning. Think carefully too about your practice, the environmental cleaning requirements that you need to be putting in place to stay safe over this period of time. And of course, communication, and I've repeated that a few times there because it is so key to getting all of this right. And I absolutely cannot stress that highly enough, that your inter-team communication, the way that you communicate with your patients around what's happening, the services that you provide and what your expectations are, you really need to ramp that up and keep that happening very frequently, at least daily, if not multi-times a day. Think about how your information is communicated to staff who may not be around all the time. So think about your electronic systems. You might want to think about, for example, using a shared folder on your computer drives where all of the information about what you're doing and how you're delivering your services can all be kept in that one place, and everybody simply looks to a central platform for any updates or any changes that have had to be implemented. Your personal protective equipment, of course, is super important as well. Remember hand washing as the key methodology for keeping your staff and your patients safe. You need to, of course, think about your other kits as well, your masks, your gloves, your gowns, and all of the other PPE that comes along with it. Some of you may know me also from the work that I'm currently doing in the space of getting hand sanitizer available for practices right around Australia. Again, there is a link available at the end. If you're struggling with that particular supply, at least we've got an answer for that. But think about the PPE that you require. It's a difficult space because that national stockpile still seems to be very, very elusive. But keep talking to your PHN about supplying you with masks and that other PPE equipment. Think about your patient education, the health literacy, and making sure that any communication that you put out there, whether it is through your online platforms or written advice, that you carefully scrutinize the language that you are using to ensure that it is appropriate for your patients so that they can understand the instructions that you are providing them. It sounds like a bit of a no-brainer, but that's actually really hard work to ensure that your communication to your patients is appropriate for your target audience. And finally, probably one of the biggest risks that is around the corner too, that you need to be really aware of, is that now that Medicare have relaxed the rules around who can provide telehealth services to patients, that's been changed. So in the last few weeks, patients needed to have attended a practitioner or a practice in the last 12 months in order to be able to provide telehealth services. And those requirements are now gone. And what that means is that any practitioner anywhere in the country is able to provide a telehealth service to your patients. And that is absolutely a huge risk for practices who are not doing so well in this space of providing telehealth services, because patients can get it at other places where the technological platforms are well advanced and really schmicko. So you can't afford to not be playing in this space, because you will see your patient clientele go elsewhere. Similarly, I had a conversation with a practice just this week, and we were talking about the fact that, you know, frequently GPs can keep patients waiting for a long period of time, and that in this online space, for a patient to be sitting in front of a screen or on a telephone on hold for half an hour or an hour is absolutely unacceptable, and it's going to create sort of leakage to these other providers. So think really carefully about how you can maintain that service quality so that your patients will continue to see value in sticking with their medical home. That is so important for ongoing care and continuity of care. So just be really aware of that risk that is out there now. Couple of tips and hints, and I do want to move it on because we've only got a couple of minutes before we need to hand it over. Think about your reception space and how you can introduce some barriers there. Look at removing some waiting room chairs. Look at visual signage within your practice to guide patients of where to go and how to behave. Look at some overt signage to make it really clear. The hand sanitizer, I've spoken about that, and think about privacy considerations at both ends of telehealth and telephone consultations. Do some scenario planner. Think about how your practice is going to respond if some of your staff get sick, or if lots of your staff get sick, or if your personal protective equipment is not available. I won't spend too much on the ethics of safe service provision, but think too about how you might be challenged to which services are going to take priority. So your triaging is going to really come to the fore in a very, very tangible way, where you're going to have to perhaps not be able to service some patients because you are prioritizing higher need ahead of that. That's difficult to do. That's very challenging. It's very unpleasant. But you might want to think about those conversations before you're in that space of having to make the decision, just so that you are primed for the kinds of thinking that needs to apply there. And of course, not a one-size-fits-all. Different practices are going to have different priorities. Care for your staff. Think of the emotional impact that this is all bringing. There is a lot of fear out there. Think about your breaks and your team catch-ups. your patients and your staff have family needs as well. So just be mindful of what those requirements are. Be kind, generous, and care for those around you. So we all need to be gentle, I guess. And I'd really encourage you to think about your leadership in terms of how you are responding to both your staff and your patient needs. It's okay to be vulnerable. Your communication, leadership, and adaptability to that rapid change space is going to pay dividends if you can do that well. I've spoken about your new competition, and you need to think about how you continue to best serve your patients. And of course, there was a little bit of doom and gloom in that, but there are definitely opportunities in this as well. Look at utilising your nurses, especially in the space of chronic disease management. If you're finding that your patient numbers are starting to taper off, look at your registers for your chronic disease patients and how can you better serve their needs. You can be quite proactive about ensuring that their chronic disease is well looked after. And if you are finding that you have spare time, this is where you want to be starting off. You need to be preparing for your flu season now, and that's a webinar in itself. Think about catch-up services and how you continue to deliver service excellence. I think I've covered that reasonably thoroughly there as well. The space beyond, COVID-19, develop your systems with longevity in mind. And I would really encourage you to just slow down a touch and think about what is going to be happening next. How does that apply to your situation? All right, so we might flip through to some questions, and as I will get the moderator back on the line to have a talk about what your questions might be, we've got just a couple of minutes. I'm just going to flip up the last slide, which just outlines the additional references that are available for you, and that URL that you see on your screen there. If you go there, you will have access to all of those guides and resources there as well. So let's have a look at what the questions might be.
Yeah, sure. So thanks so much for that, Rivka. Some really cool practical information in there. We've got 3 quick questions. Hopefully we've got time to answer. So the first question came from a little bit earlier in the presentation, and they asked, could you please clarify on how the assignment of benefits can be done in a practical manner for nursing home residents, for example, with dementia, who are not able to do this?
So in terms of patients who are not capable of providing, reasonable consent, there has always been provision for the GP to accept that assignment for a patient who's not capable of providing that. So if there is a carer around who is able to effect that, then that is perfectly okay. But that provision has always been there as far as the Medicare legislation is concerned, that where obvious consent can't be gained through usual mechanisms, that the GP can actually attest to that. So in that circumstance, it would be perfectly fine for the GP to notate that reasonable consent can't be obtained from the patient directly, and that will be perfectly fine. I've worked with some clients who are in a really particularly challenging space of working with youth in residential care. So frequently the actual service providers are the carers for these clients as well. So this whole notion of consent there is completely turned upside down, because the service provider actually is the authorised adult there as well. So there are some really unique circumstances, but again, just document the fact that that consent can't be provided by the patient, and that should be fine.
Cool. Thanks, Rivka. Question number 2. So for vulnerable patients, does the bulk billing incentives 10990 apply or not?
Well, look, you can try to apply it. It's a really good question, because I am not 100% certain of how Medicare would scrutinise that, because of course they usually apply the rules of the patient having a healthcare card or having a pension card or for a child under 16, they use date of birth for that for that authorization. So I'm not quite clear about how Medicare will scrutinise those additional patient cohorts. I haven't actually heard back from practice managers in terms of what they are experiencing, of whether those claims are being rejected or not. I would say, give it a go and see what happens in terms of rejections that follow after. But I'll be very happy to hear back from other practice managers within the webinar tonight too, if they've got any further experiences with that.
Great. Thank you. Question number 3. So we are a practice that is still open for some face-to-face consults, and they want to confirm that 701 or 707 is no longer payable from Medicare due to the risk to our patients aged 75 or older.
I'm not 100% clear what the question is. Certainly there is no equivalent telehealth or video consult item for items 701 to 707. So I guess that's not to say that you wouldn't want to continue to support these patients. You might be thinking, especially over the 75-year-olds, whether your care planning item numbers are a good substitute, and whether you can incorporate what you would normally do for a health assessment within that care planning framework. That might be a way around it. But at the moment, look, you would say that if a health assessment can be undertaken without needing to take physical observations, then in terms of blood pressures and heights and weights and whatever else it might be, then you could reasonably argue that those services can still continue. But I think in the spirit of what Medicare has indicated, those items are not really suitable for telehealth services.
Great. I think we've got one more question. If we just do this one really quickly, then we'll move on. Can telehealth be offered to all patients, even younger patients who are not vulnerable, but who are worried about leaving the house, for example?
Oh yes, absolutely. So the eligibility for telehealth items is now across the board. So the service can absolutely be offered to any patient at all, whether it's a youth or an adult, or for a script renewal, or for any kind of sort of simple service. That's been the massive change since these items first came out. In the beginning, the services were restricted to those vulnerable groups, but that's out the window now. So definitely you can apply these item numbers to any patient service for which you provide a telehealth or a video conferencing service, and you can bulk bill that, and that's perfectly legitimate. The only thing is that Medicare requests you or demands of you that for those vulnerable patients and concession patients, that they must be bulk billed. There is no freedom to privately charge for those services. But for other patients, you can bulk bill them, or you could apply a private charge and still apply the Medicare rebate as the bit that comes back to the patient after that. That is definitely possible.
Great. Okay, thank you so much, Rivka. We are going to move on. So Rivka will be around at the end, I believe. So if we do have some more questions,
I'll hang around.
Thank you.
Sure.
We'll move on just to make sure we get all this great information out. So next we're going to introduce Mr. Luke Googe. Sorry if I haven't pronounced that correctly. He's a practice manager at CBD Doctors in Melbourne. Luke Googe is a practice manager with 15 years experience working both private and public healthcare. He began his career working as a medical technician at the Alfred and Royal Children's Hospital, and has worked in management within Royal Melbourne and Monash Health before transitioning to specialist consulting and general practice management. So let's welcome Luke.
Thank you, Alison. I appreciate. Thank you everyone for having me on tonight. I guess my portion here. Let me just share that webcam. Bear with me 1 second. Yeah. So look, I guess that we're all in this together in terms of telehealth. It's been something that some practices have thought about for quite some time. Some have, I guess, put into place quite a fair while ago, whereas others have, essentially been, their hands have been forced, and but essentially we're all in this situation here where we're trying to work out what works best, what's going to service the patients best, what's the best outcomes and the best workflows, I guess, for the practice, and what's going to make things easiest for the doctors and provide those positive patient outcomes. So I suppose all of us are in different stages of planning in terms of our telehealth strategy, and I'm going to speak a little bit in regards to what my practice, CBD Doctors Melbourne, has been putting into place. So we started our telehealth, I guess, investigations, I guess you call them, so midway through last year. And not surprisingly, there was a lot less information out there. There was a lot less video offerings and a lot less clarity around what practices could and couldn't do. And this is obviously the COVID-19 pandemic situation's changed all that. So I guess one thing that we have to accept is that not like Rivka mentioned earlier. Actually, before I get to that, just on the 10990 and 10991 question from one of the listeners earlier, they have been approved from my point of view for our clinic, and yeah, they are accepted at the higher rate. One piece of advice would be to change the fees to the increased rate in your patient management system, and just to ensure that you don't get any sort of rejections in terms of benefits are higher or lower than what they actually are. Yeah, so I guess the systems that you're putting in place need to be suitable in the long term, and also, you need to think about what's going to make life easier for the for admin and the doctors. I don't know, Alison, were you going to do a question and answer back and forth, or would you? I've got a bit to speak about otherwise. It's at your discretion.
I think we're happy, to hear some of your things first, and we'll save the questions to the end. Love to hear about your experience here.
Yeah, certainly, absolutely. So in terms, we have transitioned from private telehealth, obviously with the introduction of the bulk bill telehealth item numbers that have come into place last week or the week before. We have since transitioned to bulk bill, so still providing telehealth obviously for non-Medicare card holders, and from our point of view, payment obviously post-consult, just to ensure that the correct item numbers are being used, which is kind of common sense really, and also if there are documents, if there are scripts and so on, make sure that these are withheld until the point in time that that private consult fee has been taken. If you're bulk billed, it's obviously not really an issue as such. But there are quite a few considerations that you should probably take into account. In terms of, I'll go through them now. In terms of the video component, phone's pretty straightforward. And I think that's going to be the go-to and going to be the easiest point of entry for a lot of doctors. But I think Todd will probably speak to shortly about the advantages and disadvantages, and I guess what might be necessary from a clinical point of view. From an administrative point of view, what we're really looking for with video is the easiest point of entry for patients. You don't want to send a link to a patient that says, please download this, please open that, please create a user account. I don't know about you, but from my point of view, as soon as you look at that, you think, too hard, and if there's another process that seems a lot easier, or you're going to switch to phone. Whereas, in a lot of situations, obviously video is going to be more suitable to the consult. We utilise GP Consult, which at the moment is a free platform, but I believe that they will be charging in the future. As Rivka and Alison also mentioned earlier, Health Direct video call has also been provided to our PHN free until June 2021. So either of those are fantastic in the point that patient gets a link, the link's opened, it's web browser based, and they've got that direct face-to-face contact with the doctor without having to go through all the rigmarole. Less areas for things to go wrong, the better. In terms of this, I guess the next step would be setting the sending of documentation, which was touched on as well by Rivka. The RACGP, we've been looking for this for a little bit of time as well. In terms of emailing encrypted documentation, 2 documents should be sent as per RACGP guidelines. The first would be the encrypted document, which would be, for example, a PDF. We utilise an application called PDF Mate, which is free to trial, but that's what we're utilising at this point in time. And then the second email would be provided with the password. So that ticks off those guidelines as far as a RACGP is concerned. Things like medical certificates for referrals and so on. In terms of the pharmacy side of things, initially we were looking at emailing to the patient, sending to the patient, which is fantastic because you've got the patient's information there. You've got their email address, you've got their home address, and so on. The cons are that they're administratively scanning through an email, sending it off, postage stamps, so on, takes time, and it also costs money. What we've transitioned to recently, obviously with the changes, I think as of yesterday, with the pharmacies being able to accept Schedule 4 scripts directly to the pharmacy without having to send off the script itself, but in terms of a hard copy form. So that can pose a couple of problems administratively as well. One of the main ones is ensuring that we have the right email address, the right fax number. Is the fax going to be communicated to the reception staff at the start? Is it going to be captured by the doctor? There's all this back and forward. And this brings me to setting patient expectations and I guess setting the whole telehealth consult from the beginning. And this is where it can be a lot less stressful on doctors and a lot less stressful on the reception or admin team, your nursing team. In terms of setting expectations, letting them know, again, as Rivka said, about the process. Does the doctor call? Does the patient call? What are the wait times? Is there going to be a download if you decide to use a video process, or is there going to be a phone call? Setting these in a short delivery from your reception team or through your booking system at the start makes life a lot easier down the track, rather than getting that call, I haven't heard from the doctor yet. Have they called? It's, their appointment was at 2:30, it's 2:32, and they're wondering, are they supposed to call? They're going to receive the call. So nip that in the bud. Also, when the appointments are being made, in terms of scripts and pharmacies, if you let them know that, do they have a pharmacy of choice, and can they have the fax number or the email address prepared, or even the phone number? Any of that makes things a lot easier, rather than trying to get it down the track, or giving the doctor another thing to think about, I guess. This sort of information is very easy to collect at the start, but there's always the chance of having these errors down the track. So asking patients ahead of time is always good in terms of the script side of things. And I guess the other thing too is, there's going to be a few good factors to consider. Doctors, are they willing to adapt to change? And if they're not, I guess how to massage that, and how to, I guess, work and come to a workflow that's going to ensure that the process is simple and it's not too, I guess, there's no points where patient care or things can go missing, or there's redundant or unnecessary processes. Admin staff competency and training, making sure that that they're across everything with the pandemic, not just with the doctors, but with the reception and the nursing teams. They're finding that things are changing on a daily basis, and obviously stress is quite a high level for everyone. You know, not just us working in health, but I guess for everyone sort of living through this at the moment. So, you know, training and these sort of processes, they sometimes don't get thought about and get thrown out the window, or they sort of get haphazardly smashed together. So again, back to the original, are we putting systems in place that are going to be suitable for the long term? Take the time to think about things offline and deliver it to your staff, deliver it to your docs, deliver it to your nurses, and ensure that it might not be perfect, but it's going to be the best way forward for the time being, rather than just making a snap decision dependent on, you know, the government's new MBS regulations that they've spat out today. And the other thing is technology, you know, the hardware and the software that you choose to use. I know that a few online booking engines are now bringing out their own offerings, looking at their options. I think that timed, I guess, booking processes where links get sent off to patients right on the appointment time can be a little bit fraught with danger. You know, docs run overtime, you know, clinics run overtime. We're in the middle of flu season. Nothing really, nothing sort of is sort of cookie cutter and really set to a schedule. So think about how you're going to take control of that telehealth process. You're going to deliver it to a patient and to the rest of the team with a sense of direction. Because that's what we all need right now. You know, there's enough uncertainty in the world at the moment. We do have, you know, if you're lucky enough to get access to flu vaccines at the moment, you'll have flu patients coming out your ears. So make sure that it's right from the word go, and you know, you set these processes in place that are going to be feasible at your best times and at your worst times. I guess that's my my take.
Great, thanks so much, Luke. Some really cool stuff there. Now, just looking at the time, what we might do is we might move straight on to the next presenter and do all the questions at the end, and then we'll sort of wrap it all up with all the questions for those that are able to stay. So thanks again, and we might move on. I'll just bring up my next screen if I can. Okay, so next up we've got Dr. Todd Cameron. Very lucky to have him here with us tonight, albeit briefly. Hopefully we can get everything done here. So Todd Cameron is a general practitioner with over 20 years experience, mostly in the western suburbs of Melbourne. And in addition to being a great GP and an all-round nice guy, he takes an active interest in mentoring and teaching doctors, the doctors of tomorrow. So let's welcome Dr. Cameron.
Thank you. You can probably pull that down. It should say M3 Health, by the way, but that's another story. Modern Medical was what I set up a while ago. That was sold, and here I am. So I would really like to do a little bit of a talk back, if you like. So Alison, if you want to put your camera on and just man the chat, as it were. I can't seem to see the chat coming directly to me, but this last bit. So you've had some awesome information there from Rivka and from Luke, and I don't know that you need more information, but you might need some clarity around some of those points. So any questions you have, then shoot them through to Alison. And then what I'm going to do is have a crack at a screen share if I can. I was just figuring out how I can do that, though, just so I can do some drawing. Can I do a bit of drawing while we're waiting? Is that possible on my iPad here?
Possibly, we'll see. Not. We'll get Mads working on that one to see if we can get your screen sharing.
All right. So
I do have a question in the meantime, if you did want me to fire.
Oh yeah, cool. Go ahead. Yep, awesome.
Yeah.
All right. I'll
so there's
get
a question
the
that came
up while we're talking.
Great. So there's a question that came through. Can telehealth be offered to patient consults for work cover and TAC?
Yes. I believe both of those, the answer is yes.
Yep. This one came from a bit earlier. So just for some clarification, does a hard copy need to be posted after faxing or emails to do with your scripts?
So the current, up until yesterday, the answer was needed to get to the pharmacy within 14 days. Now they're saying you need to keep it for 2 years. The e-solution will hopefully, be one that means we don't have to do all this other palaver at the end of it.
Yep. And I've just got one more question there. So if you've got so if you've got questions, guys, just make sure you type them in. It was again from a bit earlier around the codes. Why can we bill a 715 but not 701 to 707s?
I think that's simply because the government has determined that Aboriginal and Torres Strait Islanders are particularly vulnerable groups in the COVID crisis, and it's probably better not to get too fussed about what can and can't be done, but just play the cards you dealt. I've heard a lot of people kind of sooking about these things and how hard it is to privately bill and so forth. I think we just have to be grateful that we can continue to serve our communities and just focus on the rules that we have to play by and get to the job.
Yeah, cool.
Now, I was going to draw a beautiful pyramid, and I can describe it because it seems that the system, and I'm a Zoom native, so I know Zoom, love that space. What I want to walk you through is the way that we're approaching this. So just the fundamental approach that we're using is like Maslow's hierarchy. So the bottom layer is safety, and this is safety for ourselves, our families, our workplace, our patients, and our community. That has to be our focus during a pandemic, and I understand thing, but we have to have a primary focus on safety. And once we've locked that layer down, it's a little bit like Maslow's hierarchy of need. Once you've got food and shelter, you can then worry about the next layer. And the next layer, as we see it, is resource allocation. So once we're happy that everybody's safe, we can then start to worry about allocating resources efficiently and effectively. And then if we can do that, we can get to the next layer, which is innovation. If we've then sorted out the resource allocation, we can worry about innovating. That means doing new things, incorporating new people in your team and new roles or new functions that didn't exist before. And the level above that is thrive. And thrive may well be a relative thing in a pandemic, but if we're able to get all the way to the top of that hierarchy, we can thrive. And I described 4 layers, but in fact there are really just 2 layers. There's basically the bottom 2, which is survival, and the top 2, which is growth. And we really want to get to those growth layers. And maybe the next thing that I just wanted to discuss was around the tools that we're using to communicate with patients. So I'm a fan of simplicity, because we need to move really fast in evolving our models of service delivery. There's no way around that. We're going to need to move quickly. And what I like during times when you need to make quick pivots is simplicity, and telephones are our go-to. So I think based on the research, telephones will solve probably 80% of the issues that we deal with our patient encounters. And the remaining, if you imagine this like traffic lights, so you probably get a green light for 80%. Most of the problems you can solve on the telephone, and adding video would not really add that much to the context. There's probably 15% where it's an orange light, and you go, you know what? Laying eyes on this person would be useful. It's not mandatory, but it would be a nice confirmation, and it would help us a lot with knowing where to next. And the last one is the red light, where you go, you know what, I really can't make a decision here without actually seeing this person and laying eyes on them. And that might be a skin lesion, it might be a neurological examination, or it might be, abdominal pain, something where you think, you know what, I really can't solve this remotely. And so the way that we've determined that we're going to manage this is those 20% of patients that cannot be well served by telephone, we're just going to refer them into an essential examination clinic. We've set that up fairly easily. It can only be booked by GPs, or the nurse could book it if they wanted to, but they're all following a teleconsult. So teleconsult in the afternoon, as long as we get 12 patients at least, there are 6 patients per hour booked in, because the consult's been done prior by phone. They're coming in to have one particular need addressed. One doctor is running the session for the day. That doctor's in PPE. We treat it as if that safety layer is critical. So the doctor is dressed as if they were seeing COVID positive patients. Otherwise, it's not reasonable to have somebody doing that work. And they'll see between 12 and 18 patients. So they start at 3 o'clock. They'd finish by 5 at the earliest. If we don't get 12 patients, we'll rebook them to the next day. Until we get enough. Otherwise, we can't conserve the PPE. And then at the end of that examination period, that doctor is treated like somebody who would finish up in theatre. They would go home straight away. When they get home, put those clothes in the wash, jump in the shower, then say hi to their family. And we've made sure that the people that nominate for the essential examination clinic will have to enjoy and be good at examining patients, but they also have to be low risk for COVID complications. You know, we're not inviting any of the older doctors or with comorbidities that would mean that they are at increased risk of exposure. And essentially, we're just building these clinics, the service delivery models, as if they would be sufficient throughout any stage of the pandemic. We're not sort of saying, well, this is early, we don't need to worry about taking appropriate precautions. We'll be running that the same all the way through. And the last bit about the telephone really comes down to the telephone's one part of the whole encounter, you know, the consultation, I'm going to say, but there's actually a pre-consult and a post-consult that are pretty messy, and I'd strongly encourage you all to spend your time on tidying up those workflows and automations as much as possible before you worry about whether you go video or any other more complex means of delivering care over the telephone. One last consideration is you don't get paid more for video, but you will certainly be paying for those video services in time, if not now. And so they will actually cost you more to deliver. I think they'll go for longer. Our research suggests they do. People talk about your hair, what you're wearing, what's in the background, like my Tigers jersey. And there are a lot of other distractions. Yes, we do get information from that, but you know you're going to get a fair bit more conversation around things that don't relate to the consult. So we've locked them down to telephone only. As I said, we solve the problem of seeing patients by the essential examination clinic. And then we're spending all our time optimizing the pre-consult and the post-consult. Like discussed earlier, you know, our call volumes have been around about double for reception. So we're doing everything in our power to automate the front end process and the appointments to lay down the right expectations, etc. before the phone call takes place. We do outbound phone calls, just for clarity, just so nobody waits. The doctors make the calls out to the patients.
Great. So we've had a few questions come in, and we've got about 4 minutes left of your time, particularly, Todd, but we can sort of continue questions after if needed. So the first question, can we bill a face-to-face appointment after we have done a telehealth and bill one on the same day? So, for example, if the patient needs to come in for something else.
You can, absolutely. You don't, the 4-hour rule doesn't apply with these two consults. And, you know, it would only be a problem if you were taking the piss, you know, you were lining someone in. So if somebody came in and they had a flu vaccine done, you know, I wouldn't consider that is anything more than a 3 at best, provided you've covered off on other things beforehand. But if you talked about the flu vaccine, you consented them, then they came in and had it done, you know, you could argue that maybe you shouldn't be billing the MBS for that at all. So yeah, I think it's quite reasonable that if you're doing a consult, taking history, refer them in for an examination, that you would bill the appropriate attendance item number.
Great. Next question. So if we can bill telehealth for TAC and work cover, is it the 91800 item billed to the insurer or standard 23 for the invoice?
That's a great question, and Rivka might be better to answer that than me. I don't know is the short answer, but I would certainly ring or check the website to check the details.
Sorry, I had just checked out for a moment, so you might just need to repeat that question. I didn't quite pick that up.
The question was what item numbers do we use if we're billing for telehealth, TAC, or work cover? Are we using the same MBS descriptor for those?
Yes, I would imagine that you would be using the same descriptors. I would keep it exactly the same.
That was my thought.
That PAC and work cover will be supplying their own information about those schedules, and I think from what I've heard, and I don't have verification of this, that the amounts that they're paying are the same as what they pay for the MBS, and that's, I guess, a little bit different to what it is under normal normal attendance items. But check on the TAC website and check with WorkCover, and they will be able to supply that information to you. It's been just such an overwhelm of item numbers that, you know, certainly I haven't delved into TAC or WorkCover in any kind of detail.
Yeah, okay. My understanding is they're the same. So as I say, you can try it and bill it and see what happens. You'll be doing a lot of experimenting, get comfortable with it.
Yep.
Great. So nursing home telehealth, does a talk with an RN regarding a patient in nursing homes qualify for a consultation? And what about scripts for nursing home patients?
It should always be a conversation with the patient facilitated by the nurse. So you can't ring any more than I could ring a parent and talk about a kid and not actually involve the child in the consult, provided they're old enough to speak for themselves. It's the same as a physical consult. You know, you can't see a relative and then bill somebody else. Like it's pretty clear that the consultation has to be with the person that you're billing, and the other person is just the enabler, the facilitator that's holding the phone or whatever.
Yep, I'd concur with that.
We've just had a comment from Dr. Marzuk and Rebecca Hallam, just back to the WorkCover and TAC. So Rebecca just said, WorkCover have the information very clearly spelled out on their website, and everything they've seen from TAC is that they're still working on some details, but encouraging consultations to start and saying that they will be backdated with payments to the 13th of March, just out of interest. Yeah,
that's good info.
Yeah, thanks guys. Just a comment here. So for abdominal pain, can wait until you have your 6 patient threshold, maybe a day or 2, is the question.
Well, again, you've got to exercise some judgment, but the purpose of the essential examination clinic is to preserve PPE and line up a reasonable number of patients in a row, and they would all wait in their cars and be called in by the admin support for that service at the time, and it's run in a part of the clinic that is cordoned off from other parts, so it becomes an orange zone, and you can exercise some judgment with that. But what you don't want to be doing is getting people in one by one, everybody PPs up, and you go through 20 in a day.
All right. So I think we're actually out of questions, which is very good timing because we've just gone to 7:31. They're very good. I don't think any more are going to come in. So thank you so much, guys, for coming and spending your night presenting, and for all of you at home. Hopefully you've got a glass of wine in hand and having a nice dinner in preparation for the long weekend, although I'm sure some of you might be working on the weekend as well. And thank you so much to all of you that work in primary healthcare for doing all the amazing work that you're doing. Yeah, I guess it's really appreciated by everyone, and we know that you're working particularly hard at this point in time. So as I mentioned at the beginning, we're going to send out a copy of the slides, an evaluation survey, and some extra information from tonight's session as well. So unless any of the speakers have any other comments, I think we might be good to sign off for the long weekend.
Wishing everyone a great Easter.
Go well, be safe.
Yep, take care of yourself and your family.
Cool. All right, thanks everyone, and have a great, safe weekend. Thank you.
Thanks, Alison.
Thanks.